This is the Juvenile Justice Committee for the Georgia House of Representatives. I want to welcome everybody here. We have some special guests here today, and we have a presentation that I think is an excellent part of what we do, and I appreciate Polly and all the presenters coming today and coming to our committee. I know you've done a lot of work, and I appreciate what you're doing on this, and appreciate the progress generally that's been going on in the state of Georgia, particularly with the juvenile justice system. We've had a lot of good opportunities out there, as some folks might say. Now we have, before we get into that though, I would like to recognize Chairman Powell. He has a bill, and I'm just going to hand it over to you, Chairman Powell. Let's see. What? I think it's House Bill 730. I don't think I have it.
In everybody's folder, but it doesn't. It's this one, LC 41. And
it has at the top of the first page of the bill to have LC 410580. Is that correct, Mr. Chairman? Okay, thank you. Mr. Chairman, would you present the bill?
Mr. Chairman, my good friend and distinguished members of this House committee, I bring to you today House Bill 730. As we say, it's a very simple bill. Currently, the post council, the police officer training council has established.
I'm sorry, Mr. Chairman. Has that got it now? I think so.
There you go.
Okay.
Thank you, Mr. Chairman and members of the committee. I bring to you House Bill 730. Currently under Georgia law, the Georgia Peace Officers Standard and Training Council, as currently established, has 20 members. What we've always tried to do is to have those department heads where we have anyone that requires post-certification, basically certified, trained law enforcement officers, to be members of that council. Currently, there's one according to the bill that I put in, and I'm going to ask the committee for their consideration to amend that. But we're adding the Commissioner of Juvenile Justice, since we have many of their officers that are, in fact, post-certified. And at the proper time, I would like for this committee to consider amending this bill in a couple of places to also add the Commissioner of Natural Resources, since we do have probably over 200 other certified, post-certified officers that work for the Department of Natural Resources.
All right. And now, Mr. Chairman, where you're asking for it to be amended, you want to, on line 26, after the word designee, leave that comma in, take out the word and.
Mr. Chairman, I think that on line 14,
yes,
change the word 21 voting members to 22.
Okay.
And then on line 27, after designee, and add the word "and the Commissioner of Natural Resources" or his or her designee.
Okay. All right. Okay. We have any questions from the committee? Is that you? Mr. Wilkerson?
Thank you, Mr. Chairman. This is a quick question. Is there any compensation for the members of the committee, either per diem or any other compensation?
If they're a department head, there's not, that as I understand it.
Okay, so none of these 2 additional positions will get any additional per
No,
diem
sir.
or anything?
You know, most of all of the positions that are there are by virtue of the appointees heading some other state agency or association, law enforcement association. And just as a sidebar to that, the post council, they meet, but they don't go out of the state. They generally meet day meetings, and they're done. They don't. This isn't a traveling. This is actually a working.
Okay, thank you, Mr. Chairman. We have a few other questions. Mr. Spencer?
Mr. Chairman, we've done a lot of policy work on reentry programs with the governor. Is there anybody, a representative on there that deals with that should be on this committee? This commission?
Department of Corrections has a voting member, as does the Pardon and Parole boards.
Okay, thank you.
Any further questions from the committee? Okay. One more. Who is that? Okay, excuse me. All right, is there any other questions from the committee? Any further discussion? All right, I'll entertain a motion.
I'll make a motion.
Okay.
I move a do pass.
Okay, do I hear a second? Okay, got a motion do pass and second. All right, is there any amendments? Okay.
Thank you, Mr. Chairman. I would like to make a motion that we amend HB 730 LC 410580. We'll need to obviously fix the title, but on line 14, amend 21 to 22. Strike the word "and" on line 26. And at the end of designee, put comma, and the Commissioner of the Department of Natural Resources or his or her designee.
And then a comma after designee.
Yes, that's correct.
All right, so that what the amended language will read, beginning on the first word of line 26, Warden's Association or his or her designee, comma, the Commissioner of Juvenile Justice or his or her designee, comma, and the Commissioner of Natural Resources, the Commissioner of the Department of Natural Resources. I stand corrected. The Commissioner of Natural Resources or his or her designee, comma, who shall be ex officio members of the council. And on line 14, we're changing 21 to 22. Is that correct? Is that your?
Yes, Mr. Chairman, that is the amendment.
Thank you. I have a second.
Second.
Okay, got a second. All right. Call the question on the amendment. All those in favor indicate by saying aye.
Aye.
All opposed, no. Unanimous. Okay. LC 410580 has been amended. All right, and we're back to the original question of due pass, which had been seconded. All those in favor of, well, before I get to that, okay. Before I get to that, is there any more discussion or questions of the committee? Okay, seeing none. Upon the motion do pass by committee substitute, all those in favor indicate by saying aye. Aye. All opposed, no. Unanimous.
Thank you, Mr. Chairman and ladies and gentlemen of the committee.
Thank you, Chairman Powell. Always good to have you.
My pleasure.
Now we have a little more. We have House Bill 713. That will be placed in the Welch subcommittee for a hearing. We also have, what's the other one?
725.
House Bill 725, and that's going to be put in the Atwood subcommittee. and for a hearing on that. Once these subcommittee chairmen have had an opportunity to thoroughly review the matter, then we'll bring those bills to committee according to the determinations made in subcommittee. At this time, I'd like to welcome our special guests. I see we've got a lot of folks here from GBI. We've got Arlene McGray. Is that from GBI? We have Judge Peggy Walker. What's Judge Walker? Thank you for being here, ma'am. We have from the Department of Family and Children Services, Bobby Cagle. Great to see you here, Mr. Cagle. Scott Dutton from the GBI. Lisa Dawson from, where's Lisa Dawson? Okay, great to see you, ma'am. And we have Ashley Wilcott, Office of the Child Advocate. Where's Miss Wilcott? Okay, great to see you. Thank you very much for being here. The child fatality report is something that's primary to the function of this committee and something that's necessary for the state. Thank you so much for your work on this, and we look forward to hearing your presentations. At this time, I'd like to turn the committee over to the vice chair, Mandy Ballinger, and she's going to handle the balance of the committee meeting. There's a few of us that have some other appointments at this time. Thank you, Chairman.
Thank you, Mr. Chairman. I will start off by recognizing Ms. Gray. She is from the GBI, and she's going to be making a report on the state child fatality review. Thank you, Ms. Gray.
All right, thank you. I'm happy to be here today. I will talk a little bit about the child fatality review process in Georgia and give you some of the data that we have collected for calendar year 2014. For those who may not be very familiar with the way child fatality review works in Georgia, we are a multidisciplinary review process. We are not formed to point blame or to assign culpability, but to tell a story about a child's life and a child's death so that we can improve systems and develop strategic prevention initiatives to protect other children in the community. We work very hard to provide information on individual cases and tell the story of each of those cases in our annual report that we'll be presenting to you today. The Georgia Child Fatality Review Program actually is modeled after best practices. We have local review committees in every county within the state, which is the gold standard for all child fatality reviews across the country. We have strong staff support, and we provide training and technical assistance to all of our local committees. We do this often in person. We travel across the state as needed and provide specific training to all of our teams. We also conduct high numbers of reviews that adhere to the Healthy People 2020 objectives. Those are including reviews of sudden infant deaths, reviews of deaths relating to child injuries. So we are adhering to the national standard for reviewing child death cases. We also use the National Case Reporting System, which allows us to provide our information to a national database and allows national organizations to review our data and compare Georgia to other states across the country. We have strong state support and attention to findings, as evidenced by our presence here today. We're very grateful for this opportunity. The process of the review leads to several other activities. Obviously, improving communication at the local level between those agencies that were involved in that child and that child's family. It leads to improving identification of possible cases, improving diagnosis and reporting of these cases also to other agencies in the community. We want to use that process to improve the agency systems overall. And ultimately, the goal is prevention. When all of our agencies can communicate together and share information, we can prevent future child deaths. So some data that we have collected, again, for calendar year 2014. The reviews that we conducted were on sudden, unexplained, or unexpected deaths of children. We had 503 child deaths reviewed in that year. You can see the leading category here is sleep-related. These are infant deaths. These infants died during sleep. That is always our largest category. We also have deaths due to medical causes. We have deaths due to motor vehicle incidents, homicides, and drownings. Those are typically our leading causes every year. If you look at our deaths by gender, you can see that males were much greater population of child fatalities compared to females. Our data for race and ethnicity, we do have a higher rate of child deaths in the African American population compared to whites and Hispanics, and also those of other races. So I want to give you a little bit of more detail relating to our three leading causes of death: our infant sleep-related, our medical, and our motor vehicle. So for sleep-related deaths, we use a term called sudden unexplained infant death, SUID. These are deaths that had some identified risk factors present in the sleep environment. Most of our infant sleep-related deaths fall into this category. We had asphyxia, sleep-related asphyxia. These are cases where we have obvious suffocation, overlay, or wedging, for example, that happens during sleep. And we also had several SUID medicals. And these are cases that the child has some medical condition existing already, but dies in a sleep environment. For example, a child who has pneumonia, already a compromised airway, and they're in an unsafe sleep environment. And then we had two cases that fit the definition of SIDS, which is a perfect sleep environment, an otherwise healthy child. You can see very few of our sleep-related infant deaths fall into this category. Some other demographic data for our sleep-related infant deaths. Again, most of them are African American, more than half. Again, more males than females. Most of our infant deaths, 2/3 of them, are infants younger than 4 months of age. These are very new babies. Again, more than half of our deaths occur in an adult bed, which is not the safest sleep environment for a baby. We do see a number who are found on their back. 52 were found on their back, and 61 were found on their stomach. And when we do have information from the committee reports, 2/3 of our cases involved bed sharing. These are infants who are sleeping in a bed with another person, an adult or a sibling. Some information about our medical deaths. Again, we had more males than females. We had more African Americans compared to other races. And the leading causes of these medical deaths in children were cardiovascular related or pneumonia. 9 were due to asthma, and 6 were due to a neurological or a seizure disorder. For our motor vehicle related deaths, we had more males than females. We had, in this instance, we had more children, white children compared to African American. Our older teens, 15 to 17, were almost half of our reviewed motor vehicle deaths. And this is to be expected because these are children who are more likely driving. But we did see almost half of our motor vehicle deaths were passengers. They were passengers in the vehicle. We had 23 pedestrian deaths, and they were pretty evenly distributed across ages. 7 were our toddler ages, 1 to 4. 8 were age 5 to 14, and we had 8 that were older teens, 15 to 17 years old. We did see 16 driver deaths that were reviewed. 3 of those drivers actually were 10 to 14 years old. You have our annual report. You also will see in that annual report that we have recommendations for prevention. These recommendations come from our local review committees as well as from the Child Fatality Review State Panel. Some of the recommendations that they would put forth to our legislators and agency leaders is to target suicide prevention services in schools. That is something that has come up a number of times, and to use the youth risk behavior survey data to do that. That is a rich data set that has a lot of great information. There's also a recommendation to provide youth mental health first aid training to communities to give them the tools to respond to certain issues with children. We recommend that promoting school-based health centers could increase medical homes for children and can provide immediate assistance for those children who have physical or mental health needs. We recommend increasing drug screens for parents and caregivers following a child death. This could be valuable information to help the investigation. And we recommend synthesizing public and private systems, such as data sharing and evidence-based programs, to improve the lifetime safety of children and families. We want to empower our communities to do prevention, and that means sometimes just having conversations with family and friends around safe sleep or around water safety or motor vehicle safety. This is something that we work very hard as a staff to do, and we train our communities and our local CFR teams to do that as well. So I'd like to thank you very much for your time.
Thank you, Ms. Gray. And for those of you who may not know, I am actually the speaker's appointee to the Child Fatality Review Board, so I get the pleasure of working with these fine folks all the time. So do y'all have any questions of Ms. Gray? Mary Margaret?
Are drug screens not required or mandatory or conducted in every case where there's a sleep-related death in a co-sleeping environment?
I would suggest Judge Walker to answer that question.
Not at this time, and we're working on the training issue with law enforcement. Right now, they, as far as their training goes, when they have probable cause, they are getting warrants to be able to go forward. But we are encouraging them to ask as part of the investigation for purposes of ruling out substance abuse as an issue, because we certainly can ask parents to voluntarily be screened.
It seems to me that the data supports that it's a drug-related issue that causes a death and co-sleeping a disproportional amount of time. Am I right about that?
You are. We see that when in the juvenile court, we see the petitions come after the death where we're dealing with the siblings. And when we get sufficiently into the case, that's when we're beginning to determine that substance abuse is, in fact, the primary issue.
It seems to me that would be a good recommendation then to mandate those to whatever extent you're maximally allowed. May I ask one other question, Madam Chair?
Oh, sure.
Research also shows that teen driver deaths drop by half if they're only allowed one passenger in the car as opposed to 3 passengers in the car that's allowed now. If I'm right about that, wouldn't that be another appropriate recommendation in our driving safety statutes?
Absolutely, because teens have the problem of bending to peer pressure. They're at the age where the adult influence is less, the peer pressure is more. They will do things in groups they will never do as individuals. The more distractions they have, the more dangerous it is.
So I'd like to see those. Maybe we can characterize them as more aggressive recommendations, but I think their data supported. I'd like you to consider the Fatality Review Commission to consider those.
Thank you.
Thank you, Representative Oliver. Representative Spencer.
Judge, can you please step back to the microphone?
Sorry.
Sure.
She stole my question, but I got a question, an add-on to her question about the drug screening. When you do have cases that are positive, the individual or the parent is positive for an illicit drug or whatever, how many of those cases have resulted in death? When you have a child that has, been in the bed and they've been rolled over on, and the parent has been tested positive, in those cases, is it nearly 100%? Where would you put this? Has it been studied? What's the data?
I don't know, because I really haven't looked at each of the sleep deaths. I mean, I typically review the ones within my county, and the ones within my county, I would say that it's greater than half.
Greater than half. Okay. Thank you.
Thank you. Any other questions? Paulette, Representative Braddock.
Thank you. When I'm looking at the chart that says manner of deaths, and so the homicide, is that where you have like severe abuse in the home leading to death, or what category does that fall in?
All of the reviewed homicide deaths are due to several different circumstances. Some of those are child maltreatment related, and some of those, for example, are, gang homicides or something like that.
Okay, and then you've got undetermined and then pending. So are those like when will those be determined? How many of those were?
For pending, at the time that the report was developed, the official manner of death from the medical examiner had not been released.
Okay, and then the undetermined, how long will it take to determine whether or not there was abuse or?
Again, the medical examiner at that time would rule that undetermined if their investigation did not reveal any other manner of death. So that's a final determination based on the information that they had at the time of their investigation and autopsy.
So, and I noticed there was an increase in deaths from last year to this year. What do you attribute that to?
I'm sorry, I think
Representative Braddock, I do apologize. I think I would like to interrupt. I think you're actually asking questions from the division, the department.
The DFACS report.
Yeah, and we actually have Director Cagle who's going to be speaking to that.
Oh, okay.
So possibility that he'll be able to address those concerns.
Yeah.
One more issue with the homicides. We are seeing situations in domestic violence where the perpetrator is killing the spouse or girlfriend and then killing the children and then killing themselves. And that is a very serious issue within our state.
Thank you. I appreciate that. And I think in light of Representative Braddock's questions, I think we'll go ahead and recognize Director Cagle to present for DFACS. Thank you for being here.
Good afternoon, Madam Chair. Thank you very much for the opportunity to be here. Also, members of the committee. I'm here to present the Division of Family and Children Services 2014 calendar year information on deaths of children. The information that I'm about to present is concerning children who died in calendar year 2014 whose families had a prior history in the child welfare system in Georgia within the prior 5 years. So the child that we're talking about in many cases was not born at the time that we had the involvement with the family, but was later born and then was deceased. On the second page, I just want to give you a kind of an idea of the numbers that we're dealing with in the child welfare system. This is an indication that we have a system that is definitely in flux. It is a growing system in large measure because we have a new reporting method, which is a 24-hour-a-day, 7-day-a-week call center. Prior to having this, it stood up in September of 2013. Prior to having this, we had very spotty capabilities. Oftentimes in small counties in particular, there was no reporting capability after 5 p.m. or on weekends. Now, even on holidays, we have that coverage. You can see that the total number of reports between 2013 and 2014 actually grew by 24%. You will see, if you look at the 2015 data, a similar growth for the next year. You'll also see that after you receive those reports, that really causes the entire system to grow. We had a growth of 21.6% in our family support. Those are those cases that are of less concern with regard to the risk to the child. Those that are investigations are the ones that are abusive and tend to be of more concern to us. This is a method that we use to kind of triage the number of cases that come through to try to assure that those cases that need the most attention get it the most quickly. You'll also see that another resulting growth is in our foster care system. That was an 11% growth for calendar year 14. Calendar year 15, you'll see a very similar growth. You'll also see that show up in the state budget. We also had a growth in our family preservation cases. These are cases where we find concerns, but we feel as though there is enough capability on the part of the parent to protect the child adequately to allow us to put services in the home to try to avoid breaking up the family. And so those are kind of the large numbers. On this slide, this is a very simple slide. I just wanted to show you, I'm often asked if these numbers are in addition to the Child Fatality Review Report. They're not. The very small, or not small enough, but a small circle at the bottom is the number of deaths in that we're talking about here. That's 169 for calendar year 14. For comparison purposes, that was 180 deaths in 2013, so it is a slight decrease. You'll also see here in manners of death, a lot of the children that we deal with are medically fragile. They often come into our care because they have a medical fragility that is beyond the capability of the parent to resolve. 52% of the deaths that we're talking about today are either natural or accidental. And those, again, are assigned by medical examiners when they do the examination of the child. This chart is just an illustration of where the most concern is, and I think this stands to common sense if you look at it. The most risk to children occurs at the youngest ages. So you have a great deal of children, especially between birth and 2 years of age, that are deceased. And a lot of those are related to either medical issues or the sleep-related deaths that Ms. Gray covered earlier. This is a new analysis that we did this year. In an effort to improve our report and improve the knowledge that we have around these, we engaged Georgia State School of Public Health. They assisted us in plotting these rates of death for children. So you look at the rates of death in comparison, so you can compare a very small county and a county the size of Fulton by normalizing them to a 100,000 population. The rates of death in counties that are approximately south of Bibb County have up to 50% higher rates of death than children north of Bibb County. So in the 5-year period that we're talking about, the number of children that we had history with encompassed 676,000 plus children. Of that, 169 died. If you look at that on a population basis, that's 25 deaths per 100,000 children for those that had prior contact with DFACS. The overall child fatality rate in the state of Georgia, the 1,515 children that was reported on earlier, that's 61 children per 100,000 in Georgia. Initially, when I saw this, I took some solace in that. However, in talking to our statisticians, the numbers are so small you really can't extrapolate from these that there is any difference. In summary, we would tell you that children 2 years of age or younger account for about 56% of the deaths in 2014. 53 of those were sleep-related deaths, and in my estimation, some of the most preventable deaths that we encounter. Children in South Georgia, roughly Bibb South, had a fatality rate that's at least 50% higher than north of that line. You'll notice at least because some of those areas have a even higher rate than that. 4 of the deaths reported on in this report are homicides of children who are in care during that year. 2 of these were allegedly caused by the caregiver, and these are 2 cases that are up for prosecution right now, where foster parents are alleged to have harmed the children that were in their care. Those, in this case, although it's not always the case, these were private agency foster parents as opposed to DFACS foster parents, the ones that we certify. Now, I say that not to say that there's any less responsibility on our part. I just put that out there because this has been a topic of conversation in a couple of prior sessions about whether there was an improved capability on the part of private providers versus public providers. One of the children that was in our care was also a runaway, and he was stabbed to death. This occurred, unfortunately, not too far from here in Hurt Park, over on Peachtree Street. And then the fourth child was injured by a family member and died as a result of that injury after coming into care. The other family member was a child approximately the same age as the child that died. 58% of the deaths involve caregivers with a history of substance abuse, which I think is a very important finding. And then the finding after that, 38% of the children who died had caregivers who had been convicted of crimes. We are still looking at those, trying to understand better what relationship that has to the cases and how we can utilize that information to better prevent these in the future. I think for anyone who is interested in this, and I think most people in this state are, they want to know, what do we do about this? I think adequate staffing for our agency and the allied agencies that work with public health related functions have to be a consideration. Also, controlling of turnover rates. Our turnover for our frontline social services case managers is about 36% on an annual basis, and we have to get control of that before we're able to build the kind of knowledge and experience that is required to do this very complex work. We also need a long-term cross-agency, multidisciplinary effort to engage communities and to make sure that we have adequate services in place for the children and families of our state. We also have to integrate trauma-informed practices. One of the things that you'll note in the report is that we had 6 children who, after having left foster care, committed suicide during 2014. I think that is an indication of the fact that these children have suffered huge trauma in their lives, and it is a reminder to us that we have to assure that the services remain in place even after they leave our care, if at all possible. We stress, and I stress at every given opportunity, that this is a broad community responsibility, and we take responsibility for our portion of that. I would tell you that we've not done very well in engaging our communities around these issues in the past, and that's one of the things that I've tried to do in the 20 months that I've been in this position, is get to as many parts of the state as possible. I've been in 7 of our 14 regions, talking to the community, talking to as many people as I possibly can to better understand what the communities are like and what they want for their children. And believe it or not, that differs from community to community. We also are adopting a solution-based casework model, which is a long-term strategy to improve the work that our staff does when they go into the home of a family. And that is a 28-month process that begins in July of this year. These are all elements of what I call the blueprint for change, and basically it's a very simple plan. We have to have a practice model, meaning we have to know how to engage families. We have to have adequate staffing, and then we have to engage the community in the work that we do. I think that's our way out of this. But in the 27 years that I've spent doing this work, part of me yearns for a simple answer to this, for a commonality that we could focus on that would eradicate all child deaths. The unfortunate thing that I'll tell you today is that these are very complex. The reasons behind these are myriad, and the resolution to the problem is something that will take us a long time to do. But that does not say that we don't continue to do it. I think this is one of those things that you put your nose to the grindstone, you continue to work as hard as you can, and continue to look at the data and learn what the data tells us so that we can be engaged in activities that have the best chance of succeeding in preventing these child deaths. And I'll be glad to answer your questions.
Thank you, Director Cagle. I do appreciate that, and I applaud all the work that DFACS goes. I know sometimes it's a thankless job. There was a member of the Child Fatality Review Board that slipped in. I'd like to recognize Director Keenan. Unfortunately, Ms. Gray has already presented the GBI portion, but I certainly, on behalf of the Juvenile Justice Committee, support your efforts, and your organization's support of the Child Fatality Review is to be commended. And I see that Representative Oliver has a question.
I just wanted to commend and thank Commissioner Keenan and yourself. This is watching these reports for the last 20 years or so. This is much improved, and I'm very grateful for both of your leadership on this issue. I would like to see some more aggressive recommendations, though, based on my earlier comments. Thank you.
Thank you.
Okay. Representative Holcomb.
Thank you, Madam Chair. Director Cagle, thank you for the presentation, and I wonder if you have a sense of the factors that are contributing to the high turnover rate of personnel. Is it pay? Is it the challenges and stresses of the job? Is it lack of resources? All the above?
It really is a combination. We have had to make some very strategic decisions with regard to where we invest. What you'll notice in this year's budget is that we have asked for an additional 175 caseworkers. We're still working to get to the governor's goal of 1 caseworker for 15 cases. That is a reasonable caseload. What you'll find around the state is that you have varying caseloads that run from 16 up to 30. And that is due to the fact that you have turnover, you have people out on family medical leave, a number of issues like that. We monitor that very closely and work on that, but it is a combination of things. Having too many cases, having been a frontline caseworker before, I can tell you that I can handle about 20 to 25 cases. When I started getting beyond 25 cases, I would go home at night and lay there and look at the ceiling and think, what about that child I didn't see today? And you know, the combination of the extremely high stress that you experience on the job plus not getting sleep is something that will wear you completely out over time. So it is a matter of getting caseloads down by hiring additional caseworkers. It is also about compensation. We addressed some of that in this current fiscal year. We were able to give between 2.5% and 7.5% raises depending on years of service and merit. But next year, it is my hope that we will again come back to address a career path for social workers that will help us retain them. I think the combination of those things is the resolution to the problem around turnover.
What if you don't mind my asking, what is the starting salary for somebody just getting into this line of work?
In beginning salary, a bachelor's level social worker will come in at $28,000 a year. A master's level social worker comes in at a little over $32,000 a year.
Thank you.
Thank you, Director Cagle. Representative Braddock.
Thank you. So I'll have a couple of questions. So what do you attribute the increase in deaths from last year to this year? And then what do you think is causing in the South Georgia area below the line you talked about to be increased?
Actually, the number of deaths this year is lower, that
I thought it was higher.
No,
instead of
it is actually lower.
61 per 100,000 versus 25 per 100,000.
That was actually a comparison of this year's data between the data that we are tracking here, just those that had DFACS involvement. That was the 25 per 100,000. The 61 per 100,000 is the large population, the 1,515 that Ms. Gray was reporting on. So in number terms, our numbers last year for the 2013 period was 180, this year being 169.
Mm-hmm.
You had a second part to your question, and I apologize.
Below the South Georgia line, what would you attribute that to?
You know, that's something that we're really looking at closely. I have a theory around it, and I put it forward just without anything to substantiate it at this point. If you look at any kind of child indicator for the state of Georgia, you see negative movement in those indicators as you move south of Macon-Bibb County. One of the things that's been very frustrating for me as a director is that we depend on community resources to be able to help us ameliorate the problems that families have. So if they have a substance abuse issue, we need a provider in the community who can work with them on that issue. When you get into southwest Georgia in particular, and if you'll recall, that whole side was almost purple, it was so red. it is very difficult because the distance that you have to travel in order to get the service you need oftentimes is very great. And it's because there are fewer providers in that area than are needed. So I think resources is one thing. There are probably many things that I'm not getting to yet, but certainly with the help of Georgia State, we are going to be exploring that over the next year to try to better understand what the phenomenon there is.
Okay. I have a couple of comments too. Have y'all, because I hear a lot of comments from people just over time and over the years where you've got families that, feel like they may be having been referred to DFACS for harassment, say in cases of divorce, and then and that's taxing your resources. But then families where children should have been removed and weren't, and then they end up in a fatality or whatever. So to me, calling out on the front end, where are your real cases that you really need to be spending time on, and not harassing families that really don't make sense, that there's abuse going on in the home, and so I think there's a lot of resources where referrals are made, and a process you get into that's lengthier, and on the front end it should be relatively easy to make that determination, and then working with the kids that should be referred and aren't, and they're staying in the homes, and I've even heard social workers say, well, my hands were tied and it was hard to get them out, or whatever the situation is. I don't know everything that goes into that. So can you address that? And then the second thing is, I have some friends that have applied to be foster homes, and they said the amount of hoops they have to jump through is ridiculous. For instance, one of them said, you have to get an inspection on your septic system. So I know we have a lack of resources for people that do fostering, but I think if we look at what criteria they have to meet to be foster parents, we might want to look at that, because that to me seems ridiculous to have to get an inspection and a lot of costly things that don't really go into care. We're probably missing out on a lot of good foster homes because of that. I just wanted to make that comment.
Absolutely. And Madam Chair, with your permission, I'll
sure.
answer those.
Mm-hmm.
I would assert to you that, and your concerns with regard to those cases that are reported to us that are not indeed instances of child maltreatment, certainly we would love to be able to take those out of consideration on the front end. Unfortunately, what we have is we're presented with a set of allegations that, if taken as true, would constitute child maltreatment. And so it is impossible on the front end, just having the information that we have, to be able to tell the difference. And so the screening process is something that is very, very complex. It sounds simple, but it is very complex. We work on that on a regular basis, trying to be able to ferret out those that need attention versus those that don't. We also look at them, as I showed you earlier, in terms of which need attention the quickest. And so we try to take those that are presenting with a child that is an immediate risk of harm versus those that have a potential for future harm, and deal with those in a different way. We get out more quickly on the first, we go out a little later on the second ones. As far as foster parents go, we are about to engage with Clark Atlanta University in a study that is the first of its kind in Georgia that I'm aware of, where they're going to look at all the requirements around fostering. They're going to compare those to national best practices. I can tell you that many of the things that are required in Georgia are required because they're nationally required by Congress as a condition of us getting federal funding that's attached to that. However, I would tell you that the vast majority of those things I find to be very pertinent to the qualification of people getting there. The example you gave of the septic system, I think if we talk to a public health representative, they would give us very good reasons why that's in place, but we're going to be looking at that. I struggle with this because I want to make sure that we have the very best foster parents possible out there. Then I look at the instances where you had two reputable private providers during 2014 that selected foster parents that looked great on paper, had great references, passed everything, and were now accused of killing the children that they were caring for. It is extremely difficult, and I agree with your sentiments entirely, and would be glad to talk with you more about it to help you understand exactly what we do.
Oh, sorry.
What question? Aren't there indicators when you're first working in a home, though, that you would see, like a child that looks malnourished, that doesn't look you in the eye, that that can't really, they look like they're afraid to speak? I mean, you can pick up on those cues and kind of sense that there's something going on. And again, like, who made the referral? Is it a teacher? Is it a medical provider? Someone that just kind of not in the family, but I mean, to me there would be some indicators that would kind of help cull out those cases and differentiate on the front end and how they're treated.
Yes, ma'am. And being a 27-year social worker with a master's degree in social work, I can walk into a house and come out with a very distinct idea of what is going on with the child based upon my interaction with the family and my separate discussions with the child. What the challenge is that the majority of the people that we have on the front lines are very young social workers with very little experience, and most of them have a bachelor's level education in this area. What happens to us is, with the 36% turnover, it is almost impossible to build the kind of expertise, experience that you need in order to be able to make the kind of discernment that you're talking about there. That's my goal for my social workers, to be able to recognize those things. And when I see it in the case, I have the same reaction you have sometimes. I'm like, oh my goodness, you missed it. It's right here. But I also recall myself to the time when I was a brand new caseworker and probably made worse mistakes myself. But that is definitely the goal. We're trying to get a workforce that is highly capable and stable.
Is there on the front end that they go through for that, to look for those cues and signs?
There is. There's an extensive training program that they go through. It takes them about 3 months to complete that at the beginning of their employment.
Okay, thank you, Director Cagle. I do. There is one. I think we'll take one more question. Representative Spencer.
Thank you, Director Cagle. It revolves around training. When social workers are trained, and especially into the field, what's the I guess the didactic training versus the experience or competency training? What does that look like? Because if it can be improved at that level, then the recognition or the development of a sixth sense, if you will, because the more experience that you get on a situation like that, you just mentioned, kind of what's going on when you walk out of that family dynamic. So how do we improve the sixth sense of a social worker in their training? How can that be done?
I think that the training aspect of it is one piece, and the training that we do is extensive. The question that I'm trying to have answered right now is it effective? And that gets to the heart of your question. We do have components of it that are didactic. We do have other components of it that allow the people to go out into the field and practice under the supervision of someone more experienced. Unfortunately, my preference would be that we'd have a supervisor with 5 years of field experience minimum going out with those people. Because of the turnover we're experiencing, especially in the metropolitan areas, we at maximum are getting 2 years of experience for the supervisors we have. So this is a kind of a vicious cycle that we're trying to interrupt, and all the things that we're doing with addition of caseworkers, upping salaries, those things are all aimed at the very thing that you're asking me about. We need very experienced people at the job. We need more experienced people guiding the work, and those are very, very real issues.
Thank you. Representative Braddock.
Okay. Hopefully this will be my last one. So some of the feedback I get, I don't necessarily think the turnover is based on salary or competency or whatever. I think from what I hear, it's the overload of casework. So if you can teach them on the front end to cull out those those cases that are really wasting a lot of time and resources, and get them really focused on the ones that need more attention. I think that would relieve a lot of the stress and pressure on the social workers and help the turnover rate tremendously.
What I'd love to do with you, Representative Braddock, is to come sit down with you and walk you through a series of case examples and allow you to select the cases that you think ought to be screened out. In amongst those cases is going to be a child death. And so it will help you understand the level of complexity that we're working on here. Again, wholeheartedly agree with you. We don't need to be attending to those that don't have danger for children. It's just very difficult to see that on the front end of the case.
Thank you, Director Cagle. Does anybody have any other questions, members of the committee? Thank you. I do appreciate it. I appreciate all the members of the Child Fatality Review and all the support that y'all give, and appreciate the members of the Juvenile Justice Committee. I am new, as is Representative Lott, onto this committee, so I look forward to working with each and every one of you. And if nobody has anything further, we are adjourned.